a week of partying, lunch, breakfast, provided by other people. This week we come down to the reality that you're not as special as you thought, I guess. But to me and to our faculty, you're all very special to us, so just bear that in mind. But it's unlikely that we'll be taking you out to lunch as often as you're used to now, which is a good thing for you. But I'm Dr. James Foster. I'm the, I don't know what I am anymore. I'm the Associate Dean of Anatomical Sciences and Graduate Studies. And there's initials that go with that. So this is a pretty new position for me, and I'm also the director of the course in anatomy that you'll be taking, which we call the Anatomical Sciences. And we'll talk a little bit about that course with you. And first I want to introduce a little bit about the course for you and give you your objectives. I got the little guy walking across it. I like to do animation, so I do them once in a while. We're going to expect you out of this to be able to describe the anatomical position, describe the planes of section, know the terms used to describe relationships of the different parts of the human body, describe the types of anatomical motions, and for most of you, will be able to perform a lead role in a major Broadway musical. Okay, if you do that, good luck. But before we get to that, we're going to introduce a little bit of the faculty. As I said, I'm course director. I changed the title on there from what you had, so this is the newest title that I go by. I grew up in Michigan and went to Oakland University. Got my registry in respiratory therapy at the University of Chicago in the 6-week accelerated program. I don't think they do it anymore. My PhD in anatomy I got from Temple University of Michigan. University of Kentucky I did was at Wayne State, where I was a fellow in otolaryngology, so I worked right alongside of the ENT surgical residents, teaching them about basic science research. From there I went to Meharry Medical College in Nashville, Tennessee, in their anatomy department. I came in as the histologist, and at that point I met the next person that I want to introduce you to, which is Dr. Mo Udine. His name is McCarrum. We call him Mo just because it's shorter than McCarrum. Make sure that you spell it with 1 K. Whoops. I was trying to get that instead of 2. This pointer doesn't work too well. They misspelled it on his. I think, is Dr. Udine in the house? Stand up for us. This is Dr. Udine. When I met him at Meharry, he was just about to retire, and that was 25 years ago. So I was able to get him out of retirement again, and it was a real surprise to both of us. He called the school about the advertisement for the position in anatomy and getting all this information, and at the end of it he said, by the way, what's the name of the chairman there? And he said, Jim Foster. And he said, oh gosh, I can't get rid of that guy. So we had a good conversation after that. He's got a good background. He started out as a physiologist, and then he did a postdoc in an anatomy department, and the people there said, well, if you're going to be in an anatomy department, you have to learn anatomy. So he did that. Luckily for us, he's been doing it now for a number of years. Then next in line of the faculty that we have that are present is Dr. Melinda Carter. She's there in the back, and if she could stand up. Now she's a very happy person. She loves dead things, so that's why she's here. She has a background in anthropology, which goes along with that interest in dead things. She got her master's degree in it and a PhD, and then she went to medical school and got her MD degree, and just decided that she loved anatomy so much that she wanted to come back into academic medicine and help us in the anatomical sciences. So she's in a unique position that she can work both with the anatomist as well as the clinicians that we actually have involved in the course. So you've met a few of the different clinicians around here. Well, maybe you haven't yet. They stood up, I'm sure, and waved at you, but you'll meet them all a little bit later. A number of them are going to be coming into the anatomy lab and observing some of the interactions that you have with the other students, as well as giving you some tidbits of clinical relevance to what you're doing. Okay, and again, Melinda's going to act in the capacity in between those two. Next in line is Dr. Larissa Collier, who's in the back there. We dressed her up like a student last week so she could infiltrate and listen to your conversations, and she's gotten back with us, but now you know the secret's out that she's a faculty member here. She's got a very good background in a number of very interesting areas. She's got a master's degree in archaeology and another one in anthropology, and then she started coming to her senses and got a master's degree in anatomy education, and finally her PhD in anthropology. But she's well trained in the anatomical sciences, both as an educator as well as her, going along with her research in anthropology. Chrissy Wood, if you could stand up. Chrissy Wood looks friendly. She has a smile on her face. I want you to keep that smile on her face. She's the anatomy lab assistant and will be responsible for taking care of the cadavers in the lab and making sure that you take proper care of the cadavers as well, in a very important position. If she tells you to do something, you do it. Okay? Don't come to me and complain about her, because I'll tell you, what did Chrissy tell you to do, and I'll say, well, do it. Okay, because she's going to be responsible for everything in that lab. So you may not agree with something that she says, but it's ultimately for the good of our program. Hopefully at some time we're going to start a willed body program where we'll get body donations, and that's already in the process, but it takes an act of Congress to get it to go through. And I'm not kidding, it does take an act of Congress in the state of Alabama, and those things are being worked on, so that hopefully by next year we'll be able to start our program. Chrissy has a very long number of experiences in laboratory situations, including being a lab manager at a couple of very well-known organizations. Now, before I get to this, there's two other people that you're going to see in the laboratory and up here at the podium, and one of them is Dr. George Salter, who's going to give a lecture on Friday. He'll be in the laboratory on Wednesday and Friday as well, and he's a former director of the anatomy program at University of Alabama in Birmingham, and he's been, since his retirement, has been going all around the country and teaching anatomical sciences. Okay, one of the places he taught is Western University, which I have a past affiliation with. The other person that will be coming is Shane Tubbs, who's the editor-in-chief of Clinical Anatomy, which is a major journal in anatomy, and he's also at Children's Hospital at UAB, and he'll be giving a lecture and showing up in the lab. So when you see them, just bear in mind that they're actually part of the group and not just somebody wandering in off of the street, okay, especially if you hadn't seen them lecture yet. Okay, some things about the course. There's attendance is mandatory to the labs and to the breakout sections. Just some wonderful things up here in your book. The sector kind of indicates that this is a once-in-a-lifetime experience for you to explore the human bodies. You're going to experience a lot of different things, and you can read through all these little descriptions that are here. But the feeling that we have at this institute is that this laboratory experience is very important for your education. There's a lot of schools that have gone to pro sections where you really have no hands-on experience at this, but you all will get the hands-on experience dealing with cadavers. We also have models and other things that help you in your learning experience. A few points about professionalism, and I'll put them a little bit more geared towards this course than your overall professional attitude, which encompasses a lot more than what we'll be talking about. But some things, I put them in situations. There's one part of professionalism is responsibility and accountability, so complete your dissections on time as well as you can. Arrive to the lectures on time when someone's speaking. It's very disruptive if you come in the back. They fixed the doors a lot. They made a lot more noise before, but you can still hear them. Read your assignments on time. In fact, you're going to, in the laboratories, in particular, you're going to be expected to know what you're doing before you get in there. So we have the reading assignments ahead of time in your dissector. You should look at them because you're going to be put on the spot. If you notice, each of the labs has, except for this first one today, which is your initial meeting with your first patient, the cadaver, there's a half-hour period in between the two groups that come into the lab where you exchange information. And we'll talk about that more in the lab. The first group that had completed the dissection will tell the second group what they found during their dissection experience, anything abnormal, and so forth. Yes?
What is a breakout session?
What is a breakout session? When is?
What is?
There are breakout sessions. If I called it that, it's not really a breakout session. What did we call it, Larissa? It's a crossover session. Okay, that's the meeting. You have an A and a B group, right? Okay, A1 through 18 and B1 through 18. A1 and B1 will have the first cadaver. Okay, that's labeled number 1. That makes sense, right? That's easy. We have 18 cadavers, so 18 groups. When A1 does the dissection, B1 will come in for the rest of the afternoon. Okay, during that period of time when you're both there, A1 will tell B1 what they had done, what they had dissected out, what they found that might be unusual, and point out all the things that they had discovered. The second group will tell the first group what they're going to do. So they have read the dissection guide and are going to say, well, I'm going to do such and such a dissection and we're going to follow this pathway. Theirs will be relatively short. These will be documented, so there will be somebody designated in each of the groups that will act as both a recorder and the one that's involved in the conversations. And we'll give you more details on that upstairs. So we've got expectation is that you're going to be ready not only for the lectures but also for the laboratory experiences. Other thing about professionalism is respect, and you should show respect for your cadaver and also for the students and your faculty. Outside of this institute, I can't tell you what to do, but I think you should probably show the people in the community as much respect as you can, since you are representatives of this school. Another thing that you get out of this as far as professionalism is teamwork. You'll be working together in the labs as well as working together in exchanging information with your other groups. Some other things that would go along with this are social responsibility. If someone in your group or outside of your group is not doing as well as you are, you might want to help them. And you might want not to tell them this, but that actually will help you, because the best way to learn is to teach. So if you've got a real good handle on an area, someone else is struggling, you can talk about it. Let them know what you know. You express it, it's going to go into your brain a little bit more firmly. Okay, that's why I talk up here, because that way I remember a few things. You should dress appropriately, and the last one is show enthusiasm. So every time you go into the lab, just yell, "Yeehaw." Couple things. I sent out an email on this. You should wear closed-toed, not T-O-A-D, but T-O-E-D shoes. Because if you drop a scalpel on it, or some of the blades that we use, sometimes you might be missing a toe afterwards. So do wear that in the lab. Plus, you don't want to get embalming fluid on your feet. Okay, they won't smell very well, and dogs and cats will follow you all around. Gloves are going to be required. You have to wear those. You can purchase those together. Buy a box and share it with your group or with your friends. Of course, you have different size hands, but you can have to work that out a little bit. Suggest scrubs, and you have to purchase those somewhere. And sometimes you can get them at used stores, like the Goodwill, if you can find one around here. If you elect to wear other clothing, be willing to burn them at the end of the semester, because they're going to be kind of messy. There's 4 examinations, as you may already be aware of, in the discussions last week that are written. Along with anatomy, there'll be questions for the medical students on the molecular medicine. For the biomed students, which are mixed in amongst you all, they'll just have anatomical science questions. Okay, there's I don't know if you're familiar with the biomed program. This is through Troy University, and we have students that are working towards a master's degree in biomedical sciences, and they're taking anatomy along with the medical students as part of their training. So they're going to be here and only responsible for the anatomical sciences.
I have a quick question. If we elect to not wear scrubs because they're not in yet, do we have to wear long pants?
Yes. I meant to say that no halter tops or spandex clothing, please, or shorts. So make sure that they're long pants, because you really don't want to get anything on your that's why you wear gloves. Okay, you don't want to get them on your exposed skin. Okay, written exams are going to be worth about 60% of the course grade. There's 3 questions per hour of lecture, so there should be about 3 questions on this lecture today. But bear in mind that this is a little bit short, so there may only be 2, and we might put an extra one on another lab. But it's going to work out pretty close to 3 questions per lecture. The laboratory practical exam, which will be taken on identifying structures on the cadaver, will be up in the dissection lab, and there'll be about 50 questions for each of those exams. And there's 5 practical exams for this course, and they're listed on your next slide with the dates in that. This will all be on your calendar through CMed. Some problems that you may face, I'll just go through some briefly here that may impede with your education here, is that if you've been out of school for many years, you may feel you're at a disadvantage, but you actually may be at an advantage, who knows, but you could feel a little bit uneasy about the education process and get behind. Personal issues may develop, as well as medical issues. Your academic preparation may not have been in such a manner that it's going to be easy for you to adjust to the way things are done in medical school. So just bear these in mind. Some help that you have are your faculty advisor, your study groups, the course directors, and the course faculty, and other things that you can go along with your discussions, to learn about time management and study skills. One thing you don't want to do is get behind in your courses here. If you can get ahead, that's great. If you can stay up, that's good. If you get behind, the weight's going to get heavier and heavier on you. Okay? It may seem all right at first, but with time, you'll start feeling the stress from it, and I don't want you guys stressed. You get stressed, I get stressed. Okay? So keep up on your work. If you run into problems and you identify that you're not feeling comfortable with your learning process before the exam and that, go to your advisor and talk to them. If you start falling behind with time, go to your advisor so that they know what your situation is and they can help you in finding a remedy for whatever problems that you might have. If you're not having problems, go to your advisor too. You can have a nice chat, okay, and find out about each other. Some other issues you might have are procrastination. If you put off things, you're going to get behind, so you want to keep that up. If you party too much, this is an amusing picture I got from the chairman at DCOM. Some people actually don't really want to be here. I actually knew a physician that became a pretty well-noted cardiopulmonary specialist because I worked with respiratory therapy, so I worked with him, and all of a sudden he came up and said, I'm leaving here, I'm going to become an opera singer. He said the only reason that he got into medicine and went that far was for his father. Okay, so he didn't have a real interest in it, but I mean, it took him a long time to realize that. Some people realize it a little sooner. Okay, so that's some other problems. Your social calendar can be very busy here in Alabama. You've already had the Water World experience, so you don't need to do that again, but there's not too far in the future is the Peanut Festival. Okay, when you go to the Peanut Festival, be sure to go to the corn dog man. Okay, he's got the best corn dogs. Don't go to the other corn dogs. They may say corn dog man, but if there's not a long line to it, don't go to that one. Go to the one with the long line, and you can get some excellent corn dogs. Okay, and don't forget shopping at the Wiregrass Mall. Dr. Collier had to do that yesterday. She's already embarrassed about it, so that's all right. I used to walk around there. Other things are parties. This one, don't know if you can see, that's Dr. Philip Reynolds back there. And this big one, this tall one here is the dean. And Dr. Eugene's under all the bubbles right there. You can't see him at all. So we do have fun along with all of you. But if you go to a party like that, let me know. Okay, I may actually show up to that one. All right, so with that, that's just a little bit of tidbits about things that are maybe a part of your educational impingement. Yeah, I wanted to say a couple of things that I thought were amusing. I did listen to some of the things that Dean Lenz talked to you about. And one of them was about Western University and what the name of it was, COMP. Do you remember that? He said they called it COMP, C-O-M-P, for the College of Osteopathic Medicine of the Pacific. The reason that they've really done that is that the other name for Western University, and this is the real name for it, was the Western University of Health Sciences. The initials for that was WUS. So I think COMP came out of the better of the two decisions that might have been made. Okay, we're going to talk a little bit about anatomy now, as far as we can get with this. If I don't get through it, then you guys can, of course, look this up. These are all basic things. If this seems hard to you and difficult, that's all right, but if you look back to this later in the semester, you'll wish you had more lectures like this. Okay, just give a couple of definitions. Anatomy is the study of structure and their relationships to each other. And physiology is the study of the function of living things. Some types of anatomy are listed up here in your textbook, goes into a different definition. Gross anatomy is the anatomy looking at the things you can see with your unaided eye. So we're looking at the cadaver. Surface anatomy is a part of that. I have that listed right after it, and that's your initial view of the cadaver. And you'll do some surface anatomy today in the lab, when you're introduced to the cadaver. Regional anatomy is the way that we're going to approach our dissection, because it's the easiest way to do it. A region would be head and neck, thorax, the abdomen, the extremities. Okay, they're all different regions. The other way to study anatomy is called systemic anatomy, and that's where you study the different body organ systems. Okay. So what's some of the things that distinguish a living organism from a dead body? Can you guys give me some ideas? Yeah.
Dead body doesn't have circulation of blood.
There's no circulation. What else is it?
Breathing.
Breathing. Is that called respiration? Energy production. What was that over here? Reproduction?
Pulse.
There's no pulse. That's a simple thing. Well, let's see what I put down as some of these things. You have responsiveness. If you go over to a dead body, they usually don't respond back to you. Conductivity, that is electrical signaling within the body. They can respond if you touch them. They may move their limb away from it if they're living. They grow if you're alive. Someone said breathing. They can digest. Other functions we'll talk about: absorption, secretion, excretion, circulation was brought up, and reproduction. So these are some of the things that a living organism can do that a dead one can't. Now, organ systems are a group of organs that have a common function. You can think of one. I'll give you one of them because my question is, what are they? The digestive system is made up of a number of organs. Your oral cavity, where you take food in. Your esophagus, that brings the food down to the stomach. Stomach, the intestinal tract, and all the way out through the anal canal. So those are all part of that organ system. So if we were studying anatomy by systems, or systemic anatomy, that's what we would do. We would just study the GI system, ignore the other components of that. Okay? There's 11 of these organ systems. Okay? Your skin is a major organ system. Your skeleton and your muscles, they're all a separate organ system. You have the nervous system, cardiovascular system that pumps blood around, the endocrine system, lymphatic, digestion, digestive system, respiratory, urinary, and reproductive. We could add one more, because since there's two reproductive systems, there's a male and female, okay, for those of you that didn't know. Surprisingly, when you get into your second year, well, actually the spring of this year, you'll start looking at all these different systems, and you'll see these names again, so they're worth remembering now, but you'll know there'll be about 11 of these systems that you're going to be talking about. Some things that we have to do for anatomy is to have some common way to describe what we're looking at. Okay, so somewhere along the way, someone came up with the idea of the anatomical position. Does anyone know what the anatomical position is? Who knows? You want to show everybody what it is? Right, and you look, gaze forward, your arms are out, palms are facing forward. Feet are actually slightly apart and facing in the forward direction here. Okay? Yes?
On your last slide about the systems, would you define immune system as one of them, or not?
I think, did I have lymphatic system up there? That's the immune system. Okay? Actually, it's lymphatic and heme for blood. That's a portion of it. Okay, so that's the anatomical position, and that's so that when you talk about where something is located, you have a commonality that everybody knows when you're talking about it, they're in that position. Okay, so in the anatomical position, the thumb is pointing outward. If someone else had a different position, it was like this. If you were talking about the thumb and said, well, the thumb points outward, this would know it points inward. So you get into a philosophical argument that really has no meaning. So we went to having things in this type of position. This is pretty much what you look at when you're looking at the cadaver. Okay, they're going to be laying on their front or their back. If they're on their front, pretty much in this position. So they'd be in the anatomical position. If you're looking at a patient that was laying down on a gurney or something, it would oftentimes be similar to that position as well. Okay, if you're looking at someone just standing in front of you. So the thing with that is you're looking at a person standing in front of you, their right is on your left and your left is on their right, okay, which is can be somewhat confusing at first in that. So when we're talking about something on the right, it's not your right, it's going to be on your patient's right or your cadaver's right. So this shows the anatomical position, head facing forward, eyes looking forward as well. The upper extremity is next to the side of the body with the palms facing forward. Thumbs are on the outward side in this position. Feet are straight with a little bit of space between them. I mean the feet, the legs, the feet are pointing forward. A lot of the terminology we use, or all of it, is in relation to this anatomical position. Okay, if something is going up towards the head, it's called superior. Okay, you can do a relationship. Your heart is superior to your stomach. If we're talking about internal organs, I think most of you can get that. So the superior just means it's higher up. If someone's standing on their head and you ask the same question, it's the same answer. The heart is superior to the stomach. So it's any time you're talking about it, no matter what position the person is in, you're talking about the anatomical position. And we'll go through. Oh, this is my humorous thing about planes. All right, that's enough of that. I did this for our IT fellow here who's in aviation, or was in it, just for his enjoyment. So you could do, we could talk about planes of sections, and these are how we'll view a lot of the things that we look at in textbooks and that. A longitudinal section would be a section of a body part that goes around the long axis of that particular area. So if you did a longitudinal section of your forearm, it would be right up the long axis. Okay, if you did a longitudinal section of your leg, it would be up the leg as shown there. Transverse section is a section that goes perpendicular to the long axis. Okay, so if you took a cross section of your forearm, it would be a cut right across the forearm. Okay, so it's perpendicular to the long axis. Anything else is oblique. So if it's not longitudinal or it's not a transverse section, it's going to be oblique. So it's at an angle other than those two. So what's the importance of this? Have any of you ever seen MRIs or CT scans or X-rays? They're all like this. Okay, you've got either cross sections, longitudinal sections, or oblique sections. So the part of what you're imaging that you're looking at in all these different modalities is going to relate back to some of the sections that you could do on a cadaver. Along with this, if we're not looking at an extremity or some internal organs that we could describe with this different terminology we just talked about, if we look at a person that's in the anatomical position, there's a few planes that can be described. One is called the median plane, which is if you took a plane of section right down the front of the body and divided it into a right and left half. Okay, that's now called the median plane. They used to call it a mid-sagittal planar section, but now the preferred term is median. So it divides in the right and left. If you make a similar section that's parallel to that median section, that's called a sagittal section. So it just would also divide the body into the right and left, but it wouldn't be equal. One side would be larger than the other. And again, this, if you think about MRIs and CTs, they can do this kind of section. So you can get sagittal sections through a body and look at the relationships of the different internal organs in those bodies. A frontal section would, it's also called a coronal section, would divide the body into a front half and a back portion, okay, or anterior and posterior would be more anatomical terms. And again, you can get coronal or frontal sections of MRIs and so forth to look at how the body's put together. So you can look for things that are out of place in those particular planes. One other plane is just like transverse section I talked about before. If you make a cut that's perpendicular to the long axis of the body, that's called a transverse section. Okay, and that will divide the body into an upper half and a lower half. We call that a superior portion and an inferior portion. And again, you can get MRIs and so forth that are in these particular planes. Now there's relationships that are described according to these planes I just talked to you about, and I'll go through a few of them with you. One I'll go through doesn't quite fit in with the planes. There are some terms that's called superficial. If you're superficial, you're closer to the surface. Okay, the skin is a superficial structure to the muscles that underlie it. If you're intermediate, you're in between the superficial plane and the next one I'll talk about, which is deep. Okay, and let me go to the deep part. The deep part of a structure is that which is furthest away from the surface. Okay, so intermediate would be in between the two of them. If something is superior, that means it's nearer to the head. And if you think of a coronal section, the superior portion of it's going to be the part that's above. So if you're comparing two structures, and I think I gave the heart and the stomach before, the heart would be superior to the stomach. That's because it's above it in the anatomical position. Okay, some other terms are medial. Medial means nearer to the median plane. So if you look in the anatomical position, I have my hands out here. The little finger would be medial to the thumb because it's closer to the median line, right? Okay. Lateral means further away. Using the same thing, the thumb would be lateral to the little finger. Okay, proximal, if you're talking about something that's, and this is the best way to do it, you can also use this terminology a little bit differently and when you're not talking about an extremity, but if you're talking about an extremity like the upper limb, a part that's closer to the attachment of that limb is called proximal. So in this case, the elbow is proximal to the wrist. Okay, the converse term for that is distal, which is something that's further away from a point of attachment, which we could say the opposite, the wrist is distal to the elbow. Okay, when we're looking in internal organs, you can also use these terms comparing two organs' relationship to another, whether something's closer to it. If it's closer to it, it's proximal. If it's further away, it's distal. Okay, posterior, if you look back at that coronal plane of section where you have a back half and a front half, posterior would be towards the back. We also call that dorsal in bipeds. Anterior is towards the front. Okay, your nose is anterior to the occipital region of your skull. Okay, so it's in front of it in the anatomical position. Inferior, we talked about that. The stomach would be inferior to the heart. Few other relationships, if we're looking at the hand, for instance, and we'll come back to that. Is that me or is that someone else? Oh. What's that? Oh, do I have to go back? That will help? Okay. Well, I'm probably going to walk up there at some point, so I'm sorry. Okay, when we talk about the hand, you've got in the anatomical position, the anterior part is your palm. That's called the palmar surface. If you flip it over to the back, this is the dorsal surface. If you flip it this way, this is still the dorsal surface, and that's where the name comes from. The back here is the dorsal surface, okay, or the dorsal part of your body. Same thing with the feet. You have the inferior part of the foot, or the sole. That's called the plantar surface, and you have the superior portion, or the dorsal surface, which is the top part. And you come across these names again when we start looking at these extremities, so you know where they came from and what they mean. There's some motions that are available if you're moving something anteriorly. So if you take an extremity and you move it forward, or anterior, that's going to be flexion. And it's really good in your elbow, in the anatomical position. If you move your hand and your forearm forward, that's flexion. If you do that to your wrist, that's flexion. And your fingers, that's all flexion. The opposite is extension. So if you move posteriorly, any of these joints, that's called extension. When you get to the lower extremity, it kind of changes though. If you flex your knee, you actually bring it posterior. If you extend it, you bring it anterior. Okay, and that's just the nature of the thing, so you have to know that one exception. That must be a magical time. Okay, so that shows some other things of flexions and extensions. You can also do it with your head. So if you move your head forward, that's flexion. If at the end of this you're really pleased with what I do and you do flexion, that would be weird. Okay. Same with the hand. Flexion is moving the hand from the anatomical position anteriorly. Another way to define it, especially when you get to the knee, is that if you make the distance between the two bones in the joint less, that would fit the definition for flexion at the knee. Okay? If you do it with the elbow, the distance between the bones become less. Look at that muscle. Okay, see that? Okay. And just a few more. Opposition is when you bring your thumb directly in front of any of your other digits. Okay. Reposition is the opposite, when you bring your thumb back from those positions. And you'll learn about that with the hand. Supination is when your hand is in the anatomical position. Pronation is the opposite. Okay, and this also goes with some of the other parts of your body. Okay, abduction and adduction of the hand, and you'll be getting this in hand, is in relationship to this middle finger, which I politely reversed for all of you, but you can look at it. So if you move a digit away from that, I'll just go with this one, that's called abduction. If you bring it towards it, that's adduction. If you do it with the little fingers, it's the same thing. That's abduction, that's adduction. If you look at your thumb, it doesn't look, it's not in the same plane. Okay? So it doesn't count into this abduction and adduction type of thing. And we know flexion of the fingers is this, extension is that. Okay? Abduction of the thumb is in the opposite plane. So if you abduct your thumb, you bring it out away from the other fingers. Okay, so it's perpendicular to abductions of your digit. So that's abduction. This would be adduction. Extension is the opposite plane. Extension is kind of like abduction of the other fingers. So it'd be extension of the thumb, and this is flexion of the thumb. Did you have a question? That was your question? Okay, so it's kind of a couple things. The knee is kind of weird, and your thumb is kind of weird, okay, with these definitions. So you can learn all about those. Now, when I do these presentations, I have a lot of overlaps with what I give you, and I try to give you the final version on what you see in the PowerPoint I give you. So it doesn't always have the animations that I show you up here, because I know some of you probably converted into a PDF, or if you have OneNote, you convert it to that, and you can't see the animations. And if I put a layer over everything, you don't see anything. Okay, so I try to remove them all. If I miss one, just let me know, and I'll send those out to you. Okay, and there's abduction, is moving of the extremity, would be moving it away. If you look at the shoulder, this is abduction. This would be adduction, to bring it back. Okay, same with the lower extremity. If you abduct, you bring your leg out. If you adduct, you bring it in. Okay, if you rotate from the anatomical position, this is anterior. And if you rotate your extremity so the anterior portion is pointing in medially, that's called medial rotation. If you have it where it's going outward, that's external rotation or lateral rotation. Medial is also called internal rotation. You can do that with your lower extremity as well. Circumduction is a combination of these movements, flexion, extension, abduction, that results in a somewhat circular type of pattern. I could have you all stand and we could all go together and do this. And that would be circumduction, and be looking like we were dancing and having a good time. Dorsiflexion and plantar flexions are terms that are used for the direction of movement of the foot. If the foot is moved upward towards the dorsal surface of the foot, that's called dorsiflexion. If it's moved towards the plantar portion or the bottom of the foot, that's called plantar flexion. Okay, because it's kind of hard with the foot, especially to figure out what's extension, what's flexion. So they came up with just the terms that are related to the surfaces. So if you're moving towards one surface, the plantar surface, that would be plantar flexion, and dorsiflexion would be the opposite. Inversion and eversion, if you take your foot and you tilt it outward, okay, where my foot is at an angle like this right now, okay, that's eversion. If you do the opposite and tilt it where it's inward, that's inversion. Okay, and with that, that's actually I got through all that. I was going to plan just to let you go through it yourself, but we did go through it, and we can stop at this point and come back in 10 minutes, and I'll put on a different hat, and we'll talk about histology. Any questions?